Hello, dear colleagues and all medical students and pediatric residents. Welcome to this second International Joint Morning Report, which is held by AYMA and Children Medical Center. My name is Dr. Elmira Memar. I'm assistant professor here in Tehran University of Medical Sciences. And now I want to pass the microphone to my dear professor, Dr. Bad. He's the head manager of Children Medical Center. Hello, Dr. Bad. Could you hear my voice?
Yes, of course. Good morning, everybody. This is our honor that today's morning report is holding in collaboration with Sulaymaniyah University, which is our good neighbor and friends. And also it is my pleasure to have Dr. Faher and his brilliant team with us. Thank you so much for being with us, and enjoy to have a good morning session today. And I wish that we could have more and more collaboration in the pediatric fields together. Thank you so much. Thank you very much.
Thank you, dear professor. First of all, I want to introduce an association to you, which its name is AYMA. AYMA stands for Along Young Medics Association, which is gathering all medical students who are interested in pediatric sciences all over the world. Now, I want to ask you to watch a video clip to help you to know it better. Let's watch this video clip together. Okay, I want to say hello again to those who joined us recently. And now it's time to pass the microphone to my dear professor, Dr. Aghaei, who is the head manager of AYMA. Hello, Dr. Aghaei, welcome. We don't have your voice.
Yes. Someone needed to take the camera. Hello, everyone. I would like to welcome all of our friends in Kurdistan. We have so many good friends there, and especially I would like to thank Dr. Asu Saleh. He's a pediatric cardiologist from Sulaymaniyah University. He's a very good friend of us. He's very talented, and he's very active in the international activities. I would like to announce that we are open to any international scientific activities, and we will welcome all of our friends around the world to join us through these events. Thank you very much, and to you, Dr. Memar.
Thank you, dear professor. And now it's time to tell you about our surprise. Today we are hosting Iraq, exactly Sulaymaniyah. And now I want to introduce one of our best colleagues there, Dr. Asu. He is one of the well-known and most talented person in pediatric cardiology. Hello, Dr. Asu. We are so honored to have you with us.
Thank you. Can you hear me?
Yes, clearly.
Okay, I'm honored to be here with all friends and teachers here in pediatric, Dr. Jamal Pediatric Teaching Hospital in Sulaymaniyah. Also, by the name of Dean Office of College of Medicine, Sulaymaniyah University, I'm welcoming everybody in Tehran University and also in other parts of Iraq and all the world. I'm happy today to be part of such a grateful event, scientific event, and we are ready.
Thank you, dear professors. And now let's start our case presentation. But before it, let me introduce our panelists by this video clip. Let's watch it. Thank you. Before I start our case presentation, I should mention that we would really appreciate if you would share your points of view in chat section, and also feel free to ask your question in it. And the last thing I should mention is links to this webinar will be shared on our social media. Now let's start our case presentation by Aylar.
Hello, everyone, dear guests and dear panelists. I want to again thanks for joining us on this International Joint Morning Report. We are here to have the second International Joint Morning Reports based on AYMA with dear friends from Iraq. I'm honored to have the chance of presenting the selected case for the morning report. Our case is, as an identifying part, a 14-year-old boy which reported to had fever and sore throat, which started 2 weeks before reference to the hospital. As describing present illness, I should tell you that the main complaint of the patient was migratory arthritis, which moves from right ankle to the right knee and then left hip. There was no history of any trauma, but the patient and the parents tell a history of using local dairy products. In assessing the past history of the patient, in family history, they mentioned that his mother was suspicious for rheumatic disease. There were no medical or surgical history, and no history of hospitalization, and also no medication which have been used by the patient. In the physical examination part, I have to mention that all the examinations were completely normal. But some points are more important that I should have mentioned for you. Skin was intact with no rashes, no edema or pain in joints with normal range of motion. Head, ear, eyes, neck, and throat were completely normal with no photophobia. In assessing vital signs, we have a pulse rate of 99 beats per minute, respiratory rates of 18 beats per minute, and oxygen saturation of 98%. Blood pressure of 112/68, and also the temperature 37.1. For assessing clinic of the patient, we gather some lab tests that you can see the reports in the tables. As the most important points, I want to read some of them. That white BC of 13.68, high ESR and CRP, ASO titer 1,600. And also gram-positive cocci smear from throat smear of the patient. At the second step, we get an EKG from the patient that in our panel will be discussed by our cardiology professor. And also we got a transthoracic echocardiography, which reported mild MR, mild TR, mild AR, and mild PR. We thought about some differential diagnoses, which include reactive arthritis, brucellosis, and malignancies. As the review of admission of the patient, you can see this chart. At first, as I told you, after the first assessment, patient admitted to rheumatology ward, tablet of naproxen per 8 hours, and ampule of penicillin G IM started for the patient. After the medical treatments, symptoms were resolved, and the patient discharged with good general condition. Many thanks for listening to the case presentation. I'm passing again the panel to my dear Professor Dr. Memar. Thanks a lot.
Thanks, Aida, for your great presentation. And now it's time to discuss our case with our panelists. First of all, I want to ask a question from dear Dr. Assari. She's a pediatric rheumatologist. Hello, Dr. Assari, welcome.
Hello, dear. I'm so be grateful to participate in this webinar.
Thank you. Could you please help us how to diagnose and treat these patients?
Yes, according to, excuse me, can I turn on my webcam? Yes, according to, hello dear colleagues. According to revised criteria in 1992, our region is divided to high or moderate grade population because the incidences of our ARF population are more than 2 in 100,000 school age people. Our patient had polyarthralgia. Polyarthralgia in revised criteria of 1992 is is divided as major criteria instead of previous major criteria migratory periarthritis. Also, our patient has two minor criteria: the elevation level of ESR and CRP and the prolonged PR interval. So our patient has one major criteria and two minor criteria, and we should have the evidence of gas infection, group streptococcal infection. The sore throat, the patient has a previous history of sore throat. Eventually, the throat cultures are negative in our patient because about 2 or 3 weeks passed from this sore throat. But the antibody, anti-streptolizine or and anti-DNA AZB would be positive, such as our patient, and we know that the increasing level are more important than one titer of ISO titer. So our patient have one major criteria and two minor criteria, and was admitted for especially for cardiac evaluation and rule out the other differential diagnosis, because when we put polyarthralgia as major criteria, we should exclude the other differential diagnosis. And the patient was admitted in our hospital, and for treatment, the first step of treatment of our patient was eradication of streptococcal or gas infection in our patient by long-acting intramuscular penicillin, benzathine penicillin. We initiated the benzathine penicillin for 2 goals. One goal is the eradication of the gas infection, even the sore throats are negative. And the second goal is initiation, the secondary prophylaxis as a first dose, and we should continue in every 21 to 28 days for continuously the second prophylaxis. The patient has arthralgia. For treatment of arthritis and arthralgia, the NSAID would be considered. Previous or traditionally, we use the aspirin for this patient. But according to evidence literature, we could use the other NSAIDs, such as especially naproxen have the new evidence on it, and we use naproxen in our patient, resolved the arthralgia significantly in our patient, and fortunately the cardiac evaluation was good. And after that, for cardiac involvement, there is no evidence that anti-inflammatory agent would be improve the outcome of cardiac involvement, but experimentally in our rheumatologic pediatric ward, we had some patient with cardiac involvement with valvulitis that would be improved with corticosteroid agent, and our plan to encounter with AR with cardiac involvement, we use the corticosteroid in these patients. And thank you very much. If you have any question, I would be grateful to answer you.
Thanks, dear professor, for sharing your insight. Now I want to continue by asking questions from dear Dr. Abdesalehi. He specializes in pediatric infectious diseases. Hello, Dr. Abdesalehi. Welcome.
Hi, good morning. Good morning. Hi, everybody. As you know, secondary prevention requires continuous antibiotic prophylaxis, which should begin as soon as the diagnosis of acute rheumatic fever. The patient who have had carditis with their initial episode of acute rheumatic fever are at a high risk for having carditis with recurrences and cardiac damage. They should receive long-term antibiotic prophylaxis will into adulthood and perhaps for life. Patients who didn't have carditis with their initial episode of acute rheumatic fever have a relatively low risk for carditis with recurrences. Duration of prophylaxis for people who have had acute rheumatic fever, fundamental AHR recommendation, including the patient's acute rheumatic fever without carditis, 5 years or until 21 years of age, whichever is longer. The patient acute rheumatic fever with heart disease without residual heart disease, no valvular disease, 10 year or until 21 year of age, whichever is longer. Patients with acute rheumatic fever with carditis and residual heart disease, 10 year or 40 year of age, whichever is longer, sometimes for life prophylaxis. Our patient has a carditis and heart valve involvement in the first episode acute rheumatic fever. Therefore, they should receive 1,200,000 benzathine penicillin intramuscular injection every 3 weeks until the age of 40. And if the heart problem persists after the age of 40, it may be necessary to receive prophylactic antibiotics for the rest of his life. Thanks for attention.
Thank you, dear professor. We learned a lot. That's the educational lecture. And now I will continue by asking the last question from dear Dr. Aghaei. But before it, there are some questions in chat section. Dear professor, could you do us a favor and answer them in chat box? Dear Dr. Aghaei, I have a question. Could you please help us? What do we expect to see in their echocardiography?
Thank you, dear Dr. Memar. As you know, ARF is a disease of all layers of the heart. You will have epicarditis, but the most important thing is that you can see the involvement of the endocard layer, and that is the most important involvement of the heart. As you can see, there is some cases of pericarditis, but this type of pericarditis does not go toward the constrictive pericarditis. You can have the coronary involvement, but it is not as significant as a disease like Kawasaki disease. You can also have myocarditis, but the myocarditis as the result of the ARF is not seen as a sole presentation of ARF and is always accompanying valvulitis. So the major thing that we are looking for in a case suspected to ARF will be the valvulitis. The most common, you should divide the presentations of the rheumatic heart disease into the acute and also chronic rheumatic heart disease. In the part of the acute rheumatic heart disease, you can see the mitral regurgitation as the most common presentation of the disease. This presentation is happened because of the involvement of the mitral valve with elongation of the chordas and also prolapse of the tip of the mitral valve. It is different from the Barlow disease. As you know, in the Barlow disease, you have diffuse thickening of the leaflet, but in the ARF, you have only the prolapse of the tip of the AML. There's also a chance for the rupture of the chorda, but it is unusual. But when happens, there will be acute heart failure, and there is a chance of death for the patient. For the aortic valve, you can also see aortic regurgitation in the acute phase of the disease. Also, aortic regurgitation is caused by the prolapse of the leaflets of the aorta. But in the acute phase, you cannot see stenosis. Stenosis mostly happens in the 4th or 5th decades of the life, and it is unusual to see it before the age of 10 or age of 15. It is very important to be alert of the disease in our countries. As you know, we are living in developing countries, and in our countries, just like Iran and Iraq are the same. There are still cases of the ARF, and we can see them here in CMS, in Children's Medical Center of Excellence. And I'm sure that Dr. Asu and his colleagues are also aware of this disease in Kurdistan. About the last thing I want to discuss is that we should differ between the pathologic MR and physiologic MR that we can see in many of our patients that are referred to the clinic. You know, one of the things that it is difficult to differentiate is the silent carditis of acute rheumatic fever from the physiologic MR of an outpatient. You know, there are some criteria that will help. For example, if you have the jets of the MR that can see, or AR, there's no difference between them, in 3 different views of echocardiography, or the length of the jet more than 2 meters, and the velocity of the jet more than 3 meters per second. These are the criteria for the pathologic MR. So it is very important to be alert of the disease and make a quick diagnosis and go for the treatment. I'm sure most of our colleagues are familiar with the treatment of these patients, but the only thing that is important is that if you have an acute MR, please do not wait for the patient to get more sick and more ill. Maybe besides the treatment, besides medical treatment, there should be another option for the surgical treatment. If I may, I would like to ask Dr. Asu for his experience with the acute rheumatic fever in Kurdistan. Dr. Asu, are you also confronting patients with acute rheumatic fever in Sulaimani University?
Oh, thank you, Professor Ihsan. Really, what we are facing here is a different situation. Acute rheumatic fever for the last 10 years even, it's very uncommonly seen here. It's mostly seen in the south and middle of Iraq, and strangely, it's very little presented or very scantily presented in the north and Kurdistan of Iraq. We don't know why, but I think one of the causes is related to extensive antibiotic use by by ordinary people in the haphazard one, which is wrong scientifically, but maybe this is one of the causes that causing eradication of that pathology related to our society here. But we are facing very little patient. Even I saw patients coming from middle and south of Iraq instead to be seen from here.
So you do not have any experiences with the patients that needs urgent surgery and rupture of the chordas during the acute phase of the rheumatic fever, huh?
Usually no here, but what we are facing cases come for complications from other parts of Iraq.
Thank you very much, Asu. It's very fortunate for you to have such a decrease in the amount and the burden of the disease in Kurdistan. So thank you very much. Shall we go for a quick review of the panelists with the clip that we have, and then we shall start the case from our friends in Iraqi Kurdistan. Dr. Bakhtiyari, please start the clip.
Now our time is over. Now, Dr. Asu, it's your turn. The stage is yours. We are all ears.
Oh, thank you. Yes, I'm very pleasure to start today with our international morning report session. As a pediatric department of College of Medicine, we are very great honor to be a partner of for Tehran University Medical Science, and really special thanks to Professor Dr. Hassan, Professor Badif, and Professor Karami, and all the panelists and the audience here. I'm really want to start immediately the case presentation with one of our fellows, great fellows, enthusiastic fellow, Dr. Samad. Now, Dr. Samad, the panel is yours.
Thank you very much, Dr. Aso, and good morning, everyone. It's a great honor for me to be part of this first joint meeting between Kurdistan and Tehran. So the case today will be about unexplained dilated cardiomyopathy with MCA thrombosis and polyarthropathy. Okay, so the case, MA is a 2-year-old male child from different city, was presented to the clinic with pallor and shock-like presentation, and he was immediately admitted for supportive care with inotropes. Now the symptoms go back to 3 days earlier when the child started to have history of flu-like illness, fever, poor feeding and movement, as well as tachypnea and fussiness. He had a history of febrile-like condition in the family, which goes back to 2 months ago, and the child got diarrhea at that time. The past surgical history were negative. On examination, the child was febrile, lethargic. He had pallor with shock-like symptoms, so poor perfusion, delayed capillary refill, and all the signs and symptoms of shock. He had decreased urine output. He had normal equal breath sounds and active precordium. Vital signs were the heart rate was 140 beat per minute, SpO2 was 98 on ambient air, blood pressure was kind of on the low side, 82 over 54, and respiratory rate was 54 cycles. Immediate echocardiography was done, which showed moderate to severe form of dilated cardiomyopathy. With moderate MR, ejection fraction was 40. With mild pericardial effusion, coronaries were normal. And we will see a clip of. Yeah, so. I will leave the comment later on for Dr. Aso. Yes. The investigation were done which showed leukocytosis. CRP was negative, LDH was high, 1010, D-dimer 2364. Pro-BNP was very high, 29,000. Troponin was 4,731. Both COVID IgG and IgM were done, which were negative. Treatment was started on methylprednisolone 30 milligram per kg per day for 3 days, and IVIG were given 2 gram per kg, and aspirin also 5 milligram per kg. Inotropes and antibiotics, diuretics were given. Now, the next day, the child drowsiness disappeared, and he became more interactive with the mom. General condition was becoming better, but still the blood pressure was on the low side, so inotropes was continued. Now, after the general condition started to become better, left side weakness started to be noted. On the following days, the general condition became much more better, and inotropes were discontinued, and ACE inhibitor added. Follow-up was done for investigation. D-dimer was 1,800 and troponin 3,000. And we can see the chart. Yeah. Now, this was the chart of the blood pressure on the days that he was on inotropes. We can see on the day 1 he was kind of on the low side, and then the blood pressure started to become much better until the inotropes, I think they were discontinued on the 4th day. So the following days, the child left body weakness and irritability started to become more prominent, and consciousness started to be disturbed. Pediatric neurologist was consulted, and brain imaging was done, which showed middle cerebral artery thromboembolism with brain edema. So mannitol was initiated, heparin given, and in addition to aspirin. Next day, the consciousness started again to become better. Follow-up echo done, still showed dilated cardiomyopathy, but with less MR. Now, investigation done for PT, PTT, and INR were normal. And because of epistaxis, so we did these investigations, and they were all in the normal range. So PT, PTT, and INR, and liver enzymes, everything. Treatment after he started, he was given another dose of IVIG, 2 gram per kg, low molecular weight heparin, 100 international unit per kg, and mannitol infusion was given, like we said. The following day, the child was still irritable. He was not sleeping well. Feeding was not good. So consciousness improved, but mannitol infusion was stopped after 24 hours because of regained consciousness. Now, the general condition became much better after another 3 days on treatment, and was discharged home on anti-failure medication, long-acting heparin, oral steroids, aspirin, and physiotherapy. Close follow-up was advised. Now, the story didn't end here. So after 2 days from being discharged, he came back again to the hospital with irritability again. Now, this time he had right leg pain, swelling of the knee joint. We can see in the picture here. So the right knee was swollen with So he had also a skin rash, which was papillovesicular rash on the elbows and knees. Investigation was done, which showed leukocytosis. CRP was still negative. Now ESR was 29. COVID IgG and IgM was negative. D-dimer increased again to 8,800 after being in the low 1,000. So treatment initiated again. IVIG was given on a dose of 1 gram per kg, methylprednisolone 30 milligram per kg, low molecular weight heparin, and diuretics. The following day, the skin rash on the joints faded away, but still the irritability persisted. He developed cracked lips eventually. Another dose of IVIG was given 1 gram per kg and continued on methylprednisolone 30 milligram per kg for 3 days according to the guidelines, and as well as low molecular weight heparin. Investigation in the following day after giving IVIG, D-dimer again dropped, became 1,396. Rheumatological tests were done for the joint swelling he had. They were all negative. Coagulation tests all normal. After 3 days of methylprednisolone on 30 milligram, the dose decreased to 10 milligram per kg for another 5 days. Meanwhile, the second CT of the brain was done, and it showed signs of improvement. Another 5 days stay in the hospital. The child became well. The general condition improved, and he was discharged home on medication. Follow-up was done after 10 days. He was moving his left arm, but still few movements in the lower limbs. On echocardiography, the heart function was better with ejection fraction 45, but still he had mild to moderate MR. Skin rash disappeared, as well as the arthritis and the joint swelling, and he was clinically stable. And this is the symptomology. Yeah, this is the course of the disease. So we can see from the beginning to the end, the child had neurological symptoms and dilated cardiomyopathy. Skin rash and polyarthritis started in the middle and then faded away. And thank you very much. And I'll give the panel to the chair. So thank you.
Thank you. I'm back again. This was our patient story, and really I appreciate our panelists to have their comments. And I'm starting with Professor Dr. Adnan. Please, Professor Dr. Adnan, he's a consultant pediatric gastroenterologist, and he's the head of medical education in our university, and I appreciate this kind of comments.
Thank you, Dr. Aso. The presentation of this case probably is in the spectrum of, let's just say, vasculitis, a sort of vasculitis that could be found in pediatric and Kawasaki disease that can involve the CNS, the GIT, the heart, many other systems. In addition to the recent era of COVID-19 that can present in the similar way. But the, let's say, unusual presentation of middle cerebral artery thrombosis was a bit bizarre in this patient. So I think going after thrombophilia, whether there was an inherited or an acquired thrombophilia presentation in this patient. While I was asking about the results of the investigation done to this patient regarding his thrombosis.
Yes, Professor Dr. Adnan, they were all done, and we did show it in one of the slides. All were normal.
I mean, let's say antithrombin, factor V laden, all they were normal.
All were normal.
So probably this is an acquired process during his disease. And his response to IVIG and steroids is also, let's say, supporting this notion that his symptoms could be due to an acquired vasculitic disease. Okay. I don't know the follow-up of the patient. He was gradually improving, but did you see him after 1 month, 2 months?
No, still the patient still in the acute phase, so it's just 1 month behind the first diagnosis.
It has been seen after this month?
Oh, no.
No, he hasn't come back. Okay, thank you very much.
Thank you, Professor Dr. Adnan, for your fruitful and very scientific comments. And now I ask Professor Dr. Ibrahim, pediatric consultant pediatric neurologist, to have his comments. And he already saw the patient, and probably he know better than me what's going on with the. Thank you. Now the panel is yours.
Okay, thank you very much, Dr. Asso, and thank you for our student presenter, and thank you for all the audience and our colleagues in Tehran Medical University. Regarding this case, I have seen him. He was in a case of acute stroke in the territory of the middle cerebral artery, right-sided, with contralateral side of weakness on the other side, and I think a few convulsions. That's all indicating that this is cerebral involvement. And I asked immediately for CT scan of the brain and CT angiography. They did CT scan. It was in favor of ischemic infarction. But CT angiography, I think they didn't do at that time. We immediately put the child on low molecular weight heparin for a few days until clinical improvement was detected, followed by aspirin. Then, in the second admission, also the child still having the hemiplegia or hemiparesis. We did another CT scan, but what was strange at that time, he got, as I remember, the bleeding in the basal ganglia. It is induced by the aspirin or induced by the primary pathology which is present in the child. Actually, we don't know what was happened exactly. What was strange is that as Professor Adnan said, this look like systemic illness or systemic response to the special infection. It was twice the COVID investigation were negative, but you have not to forget there are too many other viruses which are not COVID, still they are present. Or COVID itself may have a special strain which is not to be recognized by our investigations here. So I advise to continue on aspirin dose, but with precaution, because the bleeding started at that time in the basal ganglia, to be followed by bleeding profile, PTT, and bleeding time. And still the child, as I know, he is improving. As you know, the middle cerebral artery is the most common side of developing stroke in children and infants. And fortunately, it was on the right side, but in the left side, it is usually more severe. It causes disturbance in the mentality, disturbance in the thinking and cognitive function. But in the right side, it is more benign than the left side. And chance of recovery, usually it is not less. There is chance of recovery over months, and it is mentioned even a few years. Still, you can wait to see the getting recovery of the child, and I hope that. Thank you, Dr. So thank you for our audience.
Thank you, Professor Dr. Ibrahim. I'm now giving a panel for Dr. Khalid. Dr. Khalid, he's consultant endocrinologist, and I'm happy for his presence here. Now the panel is yours, Dr. Khalid.
Thank you, Dr. Asso, and I am honored to attend this early morning panel regarding our case. Before I am talking about the case, I have two questions for First, regarding this, there is any contact with the person with the COVID or not?
Yes.
There is history of contact with the COVID person in the family?
Yes, yes.
So when in the era of COVID, as you know, although it's rare, when there is a two-system involvement, you should raise the possibility of a pediatric multisystemic inflammatory syndrome. One of the strong differential diagnosis for this case, although I am not sure there is a fulfilled criteria according to your presentation, but as you know, there is a cardiac involvement, there is a CNS involvement, and there is a prolongation of the fever. Such situation so prolonged region that you give a 3 dose of IVIG. I think this case need further evaluation to reach a definite diagnosis. Other point, I didn't saw in your presentation the platelet count. Does increase or it's slow? Because it is normal, does not increase a platelet. Totally is normal during the follow-up. This other point, in this situation, it is indicate to continue on aspirin or not. Raise this possibility because, as you know, if platelet is normal, why you give aspirin? Does give a prophylaxis or just it's better to stop during the, if there is no evidence of thromboembolism, further thromboembolism, and if there is no increase in platelet count. In my suggestion, it's better to stop aspirin if there is a cardiac involvement and if there is no evidence of a new thromboembolism. The other point regarding the skin manifestation, there is a usual presentation for COVID, or you consult the dermatology to know the skin, which type of skin lesion. This maculopapular rash or hepatic lesion or vesicular lesion. So one of the presentation of the COVID and associated with MISC, they have a vesicular skin eruption, look like a chicken pox. And thank you.
Thank you, Professor Dr. Khalid, for your nice comments. Regarding the questions you raised in your discussion about the doses of IVIG, it was given twice. First one, 2 grams per kg once in the first time. Then on a second admission, it was given in 2 occasions, 1 gram per kg. So it's 2 grams totally in the second admission. That was about the IVIG. Then the second question about platelet, they were all the times were within normal range. And about the aspirin. Aspirin, in this case, I think there are 2 or 3 indications of it. One is for the cerebral involvement, when we did follow the low molecular heparin, then you followed by aspirin. That's the recommendation from hematologists and neurologists. Then for the heart, because there was a severe form dilated cardiomyopathy, also there is maybe a cause of that thrombus formation inside the LV and may cause embolization again. So that was we are following the patient still on aspirin. The patient is doing well. Professor, I need some comments from your sides, Professor Ihsan, and if you have any comments for this patient.
Thank you very much, Dr. Asu. First, I would like to congratulate you and your team for the good management of this patient. It was very difficult, but you have shown us that you are very talented there, and I should congratulate you for that. Yes, there are some comments from here. First, I asked Dr. Asari about the case. Dr. Asari is a rheumatologist, as you know, and she has something to share with you because we had somehow a same case here in Tehran that have been managed just like you have managed your case. Dr. Asari, please.
Hello again, dear colleagues. First of all, I thank you for your very good management in this children, because it's a difficult, really it's a difficult children. Yes, we have such patient in COVID pandemic. The children with we have we have presentation some word about this, the MISC or Kawasaki-like disorder, that the autoimmune response to COVID-19 infection in our patient. That we had some patients with neurologic involvement, such as your patient. And in this patient, we use the biologics. One patient, we have the MISC presentation, multi-system inflammatory syndrome in children. In the cardiology involvement as your patient, but your patient cardiac involvement is more severe than our patient. Also, we had the neurologic involvement, loss of consciousness, and the other symptom. I'm sorry, and we use the biologic anti-TNF inhibitor, infliximab, in our patient, and we had a really good response. He really improved after that. And the other differential diagnosis in this patient, such as MISC, Kawasaki-like disorder, are monogenic. Maybe this patient have the background disorder in rheumatologic disorder, such as monogenic lupus or antiphospholipid syndrome, or the other vasculitis. We should rule out all of these. For example, antiphospholipid, we should check the antiphospholipid level. If the parents are related, monogenic lupus should be considered in our patient. And if and the P-onco and C-onco for vasculitis, because now it's a theory about the trigger of vasculitis after COVID infection. Has some theories about this, and the P-onco and C-onco, especially P-onco, are positive in this vasculitis after COVID infection, because the theory was the netosis phenomenon, that the netosis phenomena, the neutrophil contribution with each other, positive the P-onco level in our patients with vasculitis presentation. Unfortunately, we have one expired as this patient with newly presentation of PGA vasculitis after COVID-19 infection. And we had the plasmapheresis had done for her the anti-TNF inhibitor, the cyclophosphamide, the methylprednisolone parts, but unfortunately we had lost our patient. And we have theoretically the vasculitis should be triggered in patient, but some mechanism in COVID-19 after COVID-19 infection in children, especially they have the background genetic disorder or background disease that trigger with this COVID infection. Thank you very much.
Thank you, Dr. Asu, and dear professors, the time is over. Thank you for your great case presentation and discussion. We learned a lot. Dear Dr. Aghay, do you want to say anything?
I would like to thanks again our friends in Kurdistan and also our friends here in Tehran. And I would like to ask you if you can just open your cameras so we can go for a group a photo for some souvenir of this event. And I would like to ask Dr. Asu and also our friends in Kurdistan to have your promise for another session that we can share our knowledge together. We are more than happy to see all of you. We are open to any scientific events. You can easily join us in our sessions, and we can manage another session just like this. Thank you very much. So open your cameras, and by the count of 3, I would like to ask Dr. Bakhtiyari, my very good friend, that she's now preparing for the event of the board examination here in Tehran, and she's one of the major personnel here in Tehran University of Medical Sciences to make the countdown, and we will go for the photo.
Yes, we are ready also here.
Okay, thank you, Asu.
Okay, so good morning, everyone, and it was really an honor to join this meeting here today. So I'm not going to waste your time. So please keep smiling. Please smile. I'm going to take a few photos, and I will choose the best one. Okay, so let's smile.
Thank you very much, everyone, and have a nice day and keep safe. Bye-bye.
Bye.
Bye-bye, Dr. Asu.
Bye-bye, Dr. Hassan. Thank you.
Bye.
Everybody.